There's a myth going round town that when you get older you just sit down and start rocking. Just rocking. In a way that's true, if you know what I mean. Just take a look at the senior scene. Well, it's rocking.
I'm turning it over to our presenters.
All right. So I'm Casey Rust again. I am a physician with UNC. So I am a family medicine trained physician, and I'm doing a year of training in geriatrics with UNC, so that I will be a geriatrician. As mentioned, I'm co-presenting with Crystal, who's the director of nursing at Piedmont Health, and I apologize, there's an extra R in her name, so that's my typo. We'll go on to the next slide. Basically, how we'll kind of approach today is I'm going to start with some of the basics about incontinence. What is it? What are the types? What are the causes? Just to get a better understanding so that when we talk about management, some of it will make a little bit more sense. So incontinence just means an uncontrolled leakage, and our talk about today is specifically urinary incontinence, so uncontrolled leakage of urine. There is fecal incontinence or uncontrolled leakage of stool. That's another topic for another day. I think some important things to know about incontinence is that it can vary greatly in the volume of urine loss. So some people have just, a few drops of urine that's leaked. Other people completely empty their bladder. So incontinence does not always present the same way. It can also have a range of other symptoms that come along with it. So people can have discomfort or burning. People can have urgency or feeling like they suddenly have to go. Some people experience more symptoms during the daytime, and some people experience nocturia or going more frequently during the nighttime. So those are some things to be aware of. And then I put this point at the bottom because I think it's really important. Everyone thinks that incontinence is just women, and it's not. It is more common in women, and it's more common with increasing age, but it can occur in men and women, and it can occur in people of all ages. I don't have the statistic written down right now, but it's much less common in younger adults, but in people over 50, it gets to closer to like 50% of people, and then once you get to 75, it's actually the majority of people. I think it's roughly around 75% of people that experience some amount of incontinence at some point in time. So it's really, really common. Our urine's made in our kidneys, it travels down our ureters, and it's stored in the bladder. So the bladder is like a reservoir. The bladder, most people, the bladder can hold up to about 1 liter of urine. So if you think about a 2-liter bottle of soda, about half of that is what the bladder's capable of holding, but it shouldn't hold that much. After you have about a few hundred, cc's or milliliters of urine, your body should respond to signals to want to empty your bladder. And the bladder is, it's a muscle, so there's muscle around the walls, and it requires your nervous system and that muscle to be working together to urinate appropriately. All right, we can move on. So, like I said, I think it's important to know that there's different types of incontinence. Not necessarily to know them by name, but it's important to know that not all incontinence is the same because we don't always manage it the same. And so the three main types of incontinence are called stress incontinence, urge incontinence, and overflow incontinence. Stress is that people come in and they say, when I cough or I sneeze, I leak a little bit of urine. And that's exactly what it is. It's an increase in abdominal pressure that can happen with coughing, sneezing, laughing really hard, jumping up and down, that puts pressure on the bladder and causes leakage. And I like the pictures here. So if you look at this, and this is the bladder, and this is the urethra where the urine comes out, there are muscles around that urethra that help constrict it and keep it closed so that when we don't want to pee, we don't. But what can happen with the stress incontinence is when those muscles don't work as well as they're supposed to, when they're weak, once there's pressure on that bladder, they can't hold it shut, the muscles don't hold it shut, and that's how urine leaks out. That's different from urge incontinence, which is what people used to use the term a lot, overactive bladder. The two aren't exactly the same, but they're related. And that tends to be more of a problem with nerves that causes leaking, and it tends to be more volume that people lose. And that's when patients come to me and they say, I can't get to the bathroom in time. I have to urinate, and I'm not able to make it to the bathroom before I lose urine. And that's more of that urge incontinence. It's also really common to get mixed, which is a little bit of both of those. So a lot of women, and sometimes men, have a combination of the two. And then lastly, overflow is a completely different type of incontinence, and that's usually caused by a blockage. So if the urine can't get out, then it fills up in the bladder until it ends up being lost. That can sometimes be due to nerves as well, and we'll talk a little bit more about causes. But like I said, the important thing is to know that there's different types because they're caused by different things and they're managed differently. And so this is a really wordy slide, I apologize for that, but I think it's a good visual representation that there are all kinds of things that contribute to and cause urinary incontinence. In women with that stress incontinence, that increased pressure and leaking, one of the most common things that we think about is vaginal childbirth is a big risk factor because of trauma to the pelvic floor and stretching and weakening of those muscles. So childbirth is very common cause, but doesn't have to be a cause. Uterine prolapse or bladder prolapse, so when the bladder or the uterus are down lower and the vagina or even sometimes outside, that can cause incontinence. Constipation is one that's overlooked and extremely common. So if you think about it, if your urinary tract and your bladder are right next to the colon, and your colon has stool in it because of constipation, and it causes stretching and kind of pushes on the bladder, then the two of those can go hand in hand. So constipation, backup, pressure on the bladder can cause urinary incontinence. And people do find that when they're constipated and they treat that, often the urinary incontinence does get better. Infections can be a cause. Usually you think of that more with somebody who doesn't normally have incontinence and then all of a sudden out of the blue they're having incontinence. Or if usually you're someone who only has a little bit of leaking and then all of a sudden you're having big volume loss, that change, your doctor may want to check for infections by checking your urinalysis. And usually those are associated with other symptoms like the burning or going really frequently. So then the more kind of modifiable things that we take in that can affect us. So the triad here, caffeine, alcohol, and nicotine. So very common, and they all can affect the bladder in different ways. Alcohol, it's a depressant on our nervous system, and so it can affect urination and leaking of urine. They all affect the nerves, which can lead to incontinence. So those are things that doctors will usually ask about when people present with incontinence because those are things that we can change. And then medications, so prescribed medications and over-the-counter. This is by no means an exhaustive list. It's just a couple of categories that I think are important to think about. So blood pressure medications, diuretics, things like Lasix, which people will take for swelling in the legs or for heart failure, or one of our more common blood pressure medications, hydrochlorothiazide or HCTZ. All of these work by causing us to urinate more and, as a result can increase or cause urinary incontinence. But I put a picture of Benadryl. We geriatricians are often not the biggest fans of Benadryl because it has multiple possible side effects in older adults. And one of those is problems with both urinary retention, so holding on to urine, and also incontinence. And then some medical problems. Diabetes, especially when it's not very well controlled, can be related to urinary incontinence. And problems with the spinal cord can be related to incontinence. So spinal stenosis or narrowing of the spine, especially in the lower back, can be related to incontinence. And then in men, our common offenders are enlarged prostate or history of a prostate surgery are often the most common causes of urinary incontinence. And so what do we do? I'm not going to go in a lot of detail because Crystal's going to come back to some of these points, but just a quick overview that the first line therapy, meaning what we should recommend first as providers, is lifestyle modifications. I will add to that if there's a cause back from that last page, like constipation or substance, something that we can modify, that's part of that is, trying to get rid of what the cause is. We don't want adults not to drink fluids, but sometimes what we do is adjust how and when they're drinking fluids. And a big part of that is trying to avoid fluids later in the day, so within a couple of hours before bedtime. Weight loss, so obesity is associated with incontinence, and so they have found that exercise and weight loss can improve urinary incontinence. Bladder training, this can be differences with timing, like people having set times that they're using the bathroom. So Kegel exercise, have you guys heard of Kegel exercises before? Is that a term people are familiar with? So this is an example of a kind of non-traditional way. So there are actually exercises, and I had some fun looking these up online and seeing different kind of exercises and techniques that can help. So a Kegel exercise is tightening of the pelvic floor muscles, those muscles that help us hold in our urine, that get weaker with age, with childbirth, with various things. And it's not so easy to just isolate those muscles as what people may think. And so there are a variety of ways to help with that. I have had the opportunity to work with some pelvic physical therapists. So those are physical therapists who specialize in pelvic health. Both we have them at UNC, they have them at Duke, they have private pelvic physical therapists around. But they can be excellent to help coach people through this and understanding how to really isolate and control those pelvic muscles. I have people in clinic who I'll have them try to do tighten their pelvic muscles, and you see them and they just kind of like tense their abdomen, and they're like their whole body is tight, and that's really not what we're trying to get at. But like I said, Crystal will give us a little bit more about this later. I did want to talk briefly about medications. The main point that I want to make with medications is that medications don't work for stress incontinence. So that's really why I wanted to explain that there's different types, because there are types of incontinence that don't respond to medications. And so a lot of times we'll have people say, well, I have a friend who took oxybutynin or Myrbetriq and they got better. My doctor hasn't prescribed it for me. And that could be because it's a type of incontinence that doesn't respond to medications. The other piece of that is that no meds are without side effects, and this group of medications tend to have a lot of side effects. So the first bullet up here is some of the kind of older, more traditional medications that we have used for urinary incontinence, oxybutynin being kind of the old school medication, if you will, that's been around for a long time. It can be really effective for urge incontinence, but it does have side effects, and especially as we get older, those side effects are more pronounced. A lot of people complain about the dry mouth. Constipation is possible. We as geriatricians worry more about this one, the confusion piece. Just like we were talking about before with Benadryl having what's called anticholinergic effects, this group of medications can have that as well. And so a lot of times we'll have people with dementia or cognitive impairment, and they're on these medications, and sometimes taking them away can't help with that. So it doesn't mean that there's never a good time to use them, because there certainly are. It's just something that we really have to be aware of, and it's not right for every patient. Myrbetriq, I'll just mention briefly. This is a newer medicine that's become more popular over the last couple of years. It works differently than the other group of medicines, so it tends not to have that confusion side effect, but it does come with its own risk. I haven't seen this so much in my patients who have used it, but increased blood pressure and heart rate are a possibility. And so if somebody has really uncontrolled blood pressure or high heart rate, it might be a reason for your doctor to try to avoid it. The bigger reason that I've seen people have trouble with it is it's expensive. When you have a newer medicine that doesn't have a lot of competition, the drug companies can charge more for it, and so I've had patients who have had difficulty affording it. And then lastly, tamsulosin I put up here. This is typically used with men with an enlarged prostate to help with kind of opening up the urethra to help pass urine. So again, that kind of depends on the cause for the incontinence, but just for the men who had questions about incontinence, I thought it would be important to include. And I will be honest, I know not a whole lot about these other options up here, but just to be aware that there are other options for management. These are not done by primary care providers, these are done by OBGYNs and urologists. But there are Botox injections around the pelvic floor that have been used to help with urinary incontinence. And I've heard mixed results from different people about how successful those have been. Pessaries are the device that help with prolapse. So when there's a problem with the bladder is hanging down or the uterus is hanging down, that pessary can help support it. Similarly with surgeries, like things like bladder slings for people with prolapse can sometimes be helpful with incontinence. There are also other types of surgery. So I was reading about an artificial sphincter. So when those muscles are really just not working, there's actually a surgery that can sometimes replace the muscle around the urethra. And the neuromodulators are ways for the nervous system to respond better to urination. Like I said, these are a little bit outside of my wheelhouse, but it's worth mentioning that there are times when an evaluation from a specialist might be worth considering. This is my last slide. I just think, going back to what we said a little bit at the beginning, is that the reason that we're talking about this is there is stigma around incontinence and people don't like to talk about it. It's something that with my patients, because I see all older adults, that I just ask everyone because it is so common and people won't bring it up a lot of the time. Incontinence, it's very common, and like I said, it prevents people from doing things that they used to do. A lot of people say, well, I don't go to church anymore because I'm embarrassed, or I don't go out to dinner with my family because I'm embarrassed. And that causes social isolation. It also causes depression in people. And so that's really why this is such an important issue. It's also urinary incontinence is one of the 3 most common reasons that older women end up in nursing homes. And that is a shocking fact, and it's why it's really important to be aware of it and to make sure that when it is a problem that you're bringing it up with your care team. And I think, I will turn it over to Crystal at this point, and she's going to go back through some of those practical management strategies more.
So Casey has already covered what urinary incontinence is. It's that feeling of got to go, can't hold it, right? So incontinence, as Casey already covered, it plays a big part in self-esteem, dignity, and quality of life, which are very important as you age. So my goal today is to talk about methods in which we can potentially help to manage incontinence, as well as we can prevent some potential secondary complications that sometimes occur. So avoiding drinking anything about 2 to 3 hours prior to bedtime. So what I'm not saying is not to drink, because as Casey stated, fluid intake is so important. But as you get towards your bedtime, if you can count back a couple of hours and not drink any fluids. And then the other big thing is making sure that you urinate prior to going to bed. That just helps empty the bladder out. So the other piece to that is caffeine, which was also covered. So caffeine, of course, causes, it stimulates the bladder, causes urination. So if we can also work to limit the amount of caffeine and the timing of caffeine, so approximately 4 to 6 hours before bedtime. And when we typically think about caffeine, we think about sodas, but it's not just sodas. There's tea and there's also chocolate. So just remember that. And caffeine affects us all differently as far as our body's response and the stimulation of the bladder. So everybody doesn't fall into one category. So Kegel exercises, they can be beneficial to both men and women. I have some handouts back in the back that talk about how to perform those. As Casey reviewed, it's not tightening those abdominal muscles, but it's actually tightening that muscle that's used when you urinate. So a good way to find exactly what that muscle is midstream of urinating, stop urinating. And that helps you identify which muscles you want to use to perform the Kegel exercises. So the last thing that I wanted to cover about Kegel exercises is that you may not see results immediately. That's very important to know. So it may take a couple of months to actually see that, oh gosh, I am able to hold my urine a little bit longer. So don't give up. Don't stop. So another potential option is establishing a toileting schedule. So going back to that routine. So you can typically you start by keeping a diary, right? And that's looking at how often you void or you go to the bathroom. And after you have about a week of data, and I did have some handouts, thank you, examples of how to keep a diary. What you would do is you would look to see if you can expand the time frame of when you use the bathroom again. So for instance, if I typically use the bathroom every hour, right? I would look to see if I could maybe increase the time period of about 30 minutes, or you could try for an hour and say, okay, I am going to try to see if I can wait about 30 minutes before I go to the bathroom. And so it's re-establishing a routine with your bladder. It may require the use of some products in the beginning and some additional strategies that your provider would work with you on, but that is an option. So the end goal of establishing a total-attend schedule, as I stated, is to gradually increase the time between bathroom visits. And it typically takes about 6 to 8 weeks to see results. And it is something that talking with your provider would be beneficial to help you establish a routine, and looking at your diary to see what might be feasible and if there's some other treatment options. I don't know, Casey, if you have any additional input on that. So incontinence supplies, I have noticed just personally over time that the amount and quality of incontinence supplies is getting better, and I think we're seeing that because we're recognizing as a community that incontinence doesn't affect just older individuals, and in fact it affects people of all ages. I think I recently saw where they're making regular underwear that have an absorbency bottom to it. So one, it's not bulky, it's not something that you can see from the back and think, oh goodness, that person has on a diaper. It looks like regular underwear or panties, and the material is absorbent, such that, as well as typically they have odor reducing ingredients. So therefore, you're able to have a little bit of dignity if you do have an accident. There's the pads and the inserts, so they're like your menstrual cycle pads that you may have used. They're most of the time they're longer and bigger. They work well. The one thing is that it's very important to ensure that they're changed out frequently. So while they do assist in capturing an abundance of urine, sometimes what happens is individuals use those in addition to diapers to keep from leaking. And so while the diaper itself may not appear wet, the pad is. And so anything that is wet and moist and there for a significant amount of time is not good. It could lead to urinary tract infections. The other item to just cover is especially for women, and I do see this more often than I thought, the importance of wiping from front to back, and never wiping back to front. Those are basic things that can help prevent urinary tract infections, and very important to reinforce on a regular basis. So the last item that I wanted to just cover with everyone is the use of barrier cream. There's various brands that are on the market. This is equivalent to what we know that individuals have used with babies, so Desitin cream. And so it's just a thin layer over that bottom area, particularly if you have someone who is frequently wet. that just provides an extra layer of protection for the skin. So what that leads to is prevention of ulcers and rashes that might occur. And so something that is likely less feasible or acceptable, but I will throw it out as an option. So there's durable medical equipment such as a bedside commode or a urinal. Those are items that could be used to help with incontinence. So instead of people not being able to make it to the bathroom, if you have a urinal at the bedside, that could be used, or if you have a bedside commode, and maybe it's just at night, that you put close to the bed, making sure that the pathways are clear to prevent falls. Those kinds of things are beneficial.
And just to mention for anyone watching at home or for the folks in the audience that we at the Department on Aging do have those options, durable medical equipment available for folks, part of our lending library. They're all sanitized before they go back out into the community.
That's great.
But I think, for caregivers specifically, it'd be great if there was like a very easy fix, and there's not, and a lot of it is just cleanliness, frequent changing, trying to find the ideal products, and then modifying any of those risk factors. So going back to the causes, fixing the constipation, fixing the medications that could be a culprit, are really the helpful things to try to do.
Does sleep position matter much?
To my knowledge, it does not.
Could you
It's a great
repeat the
question.
question?
Oh, there was a question as to whether sleep position affects urinary incontinence. I can't think of a reason why it would.
Although sleep in and of itself is very important, so making sure that you get a restful night's sleep. I had included it in my slide, but I didn't go over it. The body is it's hard at work when we're sleeping, so making sure that we get an adequate amount of sleep is very important for rejuvenating the body.
Do you all have any thoughts about or ways to help folks accept the use, especially when it's a caregiver trying to help support their loved one's use of incontinence products?
So the question I'll just repeat is, do you have any tips for encouraging people to use them because some people feel uncomfortable with using incontinence products? I think the best thing that I have to offer is just normalizing this and telling people the statistics of how common incontinence is. Because I think people sometimes feel isolated and alone and they think it's just them, and when they realize that the majority of people suffer with this at some point in time, as in older age, then it makes it feel a little bit less uncomfortable, a little bit less stigma.
And if you can afford it, there are products that are available that are extremely discreet. Of course, they cost more money, so that can be a factor for some people.
Thanks for letting us talk with you. We really
Thank
appreciate
you so
it.
much. This is such a decision point for so many caregivers, and I didn't realize how common for placement that really knowing there are many more ways to approach this than maybe folks necessarily think about.
We paid our dues all those years, and it's so nice to be switching gears. It's a grand new century, and it's the senior life, the senior life, the senior life for me.